Okay, sounds good. Welcome everybody to UCCCN. We're so glad to have everybody here in person. Yes, if you want to move forward, please do. I don't spit usually when I talk, so this table's even safe right here. We're so glad you guys could come out today and join us in person. For those of you who are joining us by Zoom, we wish you could be here because this has been like a really lovely morning. It's been so great to be able to connect with people in person. And we're so excited to have such a great turnout for this event. So I'm gonna go ahead and get started with our meeting for today. If I can figure out how to advance slides while looking at Zoom. There we go. Okay, so as usual, we'll follow our typical format. We would love to start with some announcements, and then we're gonna have a little bit of a discussion about an ECHO group. We'll have our learning session, and then we'll wrap up with questions and a little bit of information about our next meeting. So if you're joining us on Zoom, please go ahead and bring in your Zoom profile. We'd love to have you introduce yourself in the chat. For those of you in person, we hope you've had a chance to sign in. At the table, we have some sign-in sheets, and we'd love to have you grab a name tag as well, so everybody can connect a face with a name. Glad to be able to make those connections. So for announcements today, I apologize. Last month I was traveling for this meeting as well, and I ended up stuck on an airplane while this meeting was happening. So luckily, Eric pinch hit for me a little bit, but I wanted to bring up this announcement again about the new ABA clinic at Primary Children's in Riverton, and that they are now accepting patients ages 2 to 6, and that it said that there was a wait list, but as of now, they are actually open and running clinics. So that's great. And as I was running around introducing myself to people, some other people mentioned some announcements I thought they could share with their group. Do you want to have Esperanza? Do you want to come out? Yeah, you can come out. Sorry, it's a little tangled web of.
Good morning, everyone. I'm Esperanza Reyes with the Utah Parent Center, and I just wanted to share that we're having our next steps newly diagnosed parent support group happening at the Parent Center in person. It is starting on April 29th, so that is the last Tuesday of the month, and we have 3 scheduled sessions, including May 20th and June 24th. So if you're aware of newly diagnosed families that would benefit from joining the group, please share. I'll email the flyer to you. Thank you.
All right, does anybody else have any announcements you want to share? Okay, well, oh yeah, Dora. A reminder for, I'm gonna have to just a reminder, Dr. Carol. Here. Can you hear me if I speak really loud? I just want to make sure that people are fine. Oh, that.
Just a reminder that Dr. Frisby Carol and Dr. Ben English are doing a presentation on May 8th. I think I've given this to most of you to send out an email, but it's just the 3 weeks. If they're not able to attend in person, ever RSVPs, we're going to send a recording afterwards. So the most common conditions, welcome conditions, if issues, and how having a data analysis actually enhances the best outcome. So we'll talk about that. So thank you.
Thanks, Dora. We're almost about some prayer updates from Shriners. And let's see, so okay, so any other announcements? Okay, well, we're going to turn a little bit of time over to Sylvia Baraghoshi from the University Developmental Assessment Clinics. We're gonna have a little discussion about autism echo for care coordinators.
Good morning, everyone. Thanks for having us. I wanted to share with our team that we launching an autism echo for care coordinators. So we wanted to get your input from the team or from the group as to what topics you would be interested in going over through our FO coordinator meetings that we will be having. Any questions that you may have, it'll be based off of topics. There also will be Q&A at the end, and then also case that we could discuss while we're on. So I know that Lena sends out emails at the end of the UCCN meetings. That if you could please reply with the topics that you would be interested, we will be happy to incorporate those into our ECHO care coordination. Echoes that we will be sharing with everyone.
How do I like even get this on?
We're still working on the frequency of the echoes. More than likely it'll be every other month. For the first echo, teaming with Alina to present at the UCCN meeting itself. And then after that, also, if you want to share what time would work for you or what days would work for you. And again, that's more to come. I've been talking to Athena about just incorporating it with the UCCN meetings, just because we're already getting together at this time and we would have to carve out additional time from all the care coordinators to be able to attend the meetings.
And so we met with Dr. Carbone last month to kind of talk a little bit about this idea. And so we'd love to hear more from the group about, like, is this something that would be of interest to this group in particular? And if so, what kind of topics would you like to see an echo on? What would maybe be encouraging to attend, like, is or CME's encouragement for those kinds of activities?
I know.
Like,
I know.
Let's hear your feedback on this.
Pretty frequently, on a weekly basis, if not.
A lot of the care coordinators that are here today and out joining us virtually speak pretty often, if not on a weekly, on a daily basis, asking about resources, AV providers, any other therapies, what can I do while they're waiting to get into our clinic. So these are all topics that could also be discussed during the echo time as well.
Does anybody have any comments they want to share on that, or any input or insight?
It's set up to be aspired. Aspire, but yes.
So if for that question, Gabi asked who the presenters would be, it's going to be coordinated through Aspire. With Dr. Carbone and the leading that. And Sylvia. Other comments or questions about that? So we, yes, Eric.
Just want to say, I said it like the staffing with UDAC, and so it bar none has days of experience with autism, the referrals and how the process works with insurance and things like that. So I just want to get in front end with anyone who participates should get a lot of value from participating in the series, regardless of what their choice is.
Great. Anybody else want to chime in on like what topics you want to see in this kind of an echo format or anything like that? I guess so much more talkative in person and online. I'm excited. Yeah. Oh,
So really loud, I'm so sorry. I run a home visiting program out of Davis County, and I know for us, when we are helping kiddos get into like early intervention or get into like autism testing, oftentimes there's a wait list. And so it would be wonderful to know like what we can help these families get connected to until they're off of that wait list in those services. So that would be huge.
good idea. Any other ideas? Yeah, Natalie.
I have learned about ABA, I know it's appropriate therapy. What we run into is like, what if it's not going well? Who is the person in the program that we talk to get it adjusted? What's appropriate to ask for? But we would really like some guidance in. Once we get ABA, how do we make it actually work for us?
Great. Yeah, these are the kind of ideas that are programs. So if you have other ideas like this, please speak up. Okay, we do have a couple minutes, for, if anybody has a case they want to bring to today as well. If anybody wants to share a case, some people brought, I forgot to mention this in the beginning, but some people brought, materials to share today. They're over here on the table behind, breakfast series, so feel free to stop back there as well if you want to pick up some materials from some of the agencies that are coming today. Does anybody have a case you want to share, your question you want to bring to the group? I mean, this is like a wealth of knowledge group right here, so that it's a good question. This is the time to bring it up. Maybe struggling with the case of the moment. All right, well, then I'm gonna turn time over to our presenters for today. So we are gonna talk a little bit about what is medical home and collaborative care model. And we're gonna hear from Dusty, Frisby, and Gabi, Baraghoshi, and representing, Dusty's with Wasatch Pediatrics. And we're so glad to have her. She's gonna start us off, and then we'll move over to Gabi, who is representing UPIC, Utah Partnership, Pediatric Partnership for Healthcare Quality Improvement. Did I get that acronym right? So close. I'm gonna learn that one very shortly. And your slides are actually right embedded in here, so.
Fantastic. I'll see my notes. A little bit. Okay, I'm not holding this thing, you guys. I'm gonna set it down because I also talk a bit loud. So I've been asked to present on medical home a few times, and I know you guys are aware of what medical home is. Can you hear me? I feel like I'm shouting and it's echoing. It's a lot. So with that, I know I'm speaking to the choir. A lot of the times, let's see. A lot of the times we end up focusing certainly on care coordination. Just echoing. If we come closer, I don't know. I don't know. I feel like it was more echoey if I'm closer. Sadly. I don't know if you can think things. Okay, is that more echoey? That's better. I hate holding things. Okay, that's all right. So, this is the definition of medical home off the AAP website, right? And this is what so many of us practice, that work in a medical office. Those that work in, specialty care and of course, Eric's group does a great job of creating a medical home for those that don't have that innately, or don't view that they have that as part of the care that is offered to them. So a medical home is an approach to providing comprehensive primary care that facilitates partnerships between patients, clinicians, medical staff, and families. A medical home extends beyond the four walls of a clinical practice. It includes specialty care, educational services, family support, and more. And so one of the things I love about being part of this group is that I know if I have a patient in our practice and they are moving to Utah County, I can send them to like Utah Valley Pediatrics, and I've done that plenty, because I know they have such a great medical home. And I apologize, I've sent you guys some pretty complex patients, so at least over the years. So, but it's nice that we're also interconnected, where we can provide our kids her patients, sorry, I always call them our kids, right? They're my kids. That we can provide them with a medical home, that they know that where they can call to get support. They can call and they can get help with their school services, help navigating insurance. Kind of whatever the family needs. Sometimes it's just providing emotional support. This is, I feel like, the quintessential motto of a medical home. I have one of our care coordinators, whenever I ask her in the meeting to explain it, this is the quote she uses. And I think that everyone here has this mindset, right? Any one of the kids that walk in at any time, or any of the families we talk to, their kids can become a med home, right? A medical home patient at any time. The minute they are put in touch with our services, they have a medical home. The history of medical home, I didn't want to leave this out because this is critical to this group. We're in this history. So in 1967, the medical home concept was developed, and it was and the terminology was introduced by the American Academy of Pediatrics. In 1978, Dr. Calvin Sia in Hawaii, he put in the framework for medical home, right? So he developed an approach to primary care that is what we now know as medical home. And you can kind of see it in the 1990s is picked up. And I remember in the 90s being so tired of the word medical home. Everybody wanted a medical home. And I worked in a small practice in Park City, and the doctors we didn't have care coordination. We had medical assistants and we had 5 doctors. And they wanted to know how to get their kids into primary children's to have multiple appointments on the same day. And it was a huge challenge. It was, the doctors spent endless amounts of time on the phones. And they did all the care coordination at that point. As we kind of moved down, there was, let's see, I'm going to skip down to 2010 with the Affordable Care Act. And that's kind of when things really took off for this model of medical home that we see today. In 2013, UPIC was part of the grant that came through the National Center for Medical Home Implementation. And there were, how many practices, Gabi, that were first involved? Do you remember? 15 in Utah. And some of us were privileged enough to be involved in that and watch it evolve. Initially, the UPIC provided care coordinators for us, which was, it was interesting to see how that worked, right? And the expectation from the doctors, remember I said they wanted somebody who knew how to make multiple appointments on the same day. There was no coordinated care scheduling at primary children's during that time. And so the expectation was that these people, these care coordinators, were going to come into our practice. They were going to magically know how to do this, and that everything would be solved. The world was going to be fantastic, and our patients would be taken care of. And what ended up happening, at least in my practice, was the care coordinator that was put there was not a great fit for our office. And so as this care coordinator left, I took over that position and had to learn how to do everything that the doctors wanted, right? But this is really what kicked off this group. And so this group was produced as part of this grant in 2013. And it was so valuable to have other people to talk to and to meet in person, and to explore the different resources that we didn't know about. And so I really appreciate that this group is still going and that we still have that opportunity and the opportunity to talk about difficult cases. So. Oh, whoops, now I hit something. Oh, whoops, go back here. Okay, so this is what we know as the model of medical home, right? And the big thing that we always talk about is care coordination, because that's what we are as a group. And so I'm just gonna kind of start there. Care coordination is something that our families want. It's something that the physicians want. Even in recent surveys for, Eric, what's the name of the survey? The National Survey of Children with Special Healthcare Needs? Oh, I made it too long. Anyway, I know it's something. In that survey, families say they want care coordination. They want help understanding the system, and they need help understanding how to get access. And that's what you all do so well. Some of the other areas that we need to be really cognizant of in medical home, and we have some clinics that are certified medical homes. We do not have, as a general statement, you don't have to have a certification to be medical home. It's more of a concept of practice. For those that are certified, there are key elements in each of these areas that they have to meet in order to become certified. So you have to be accessible, right? So you're out, you have to have after hours availability for your patients, whether it's a nurse line, doctors on call. You have to have hours that are also convenient for patients. You have to take all insurances. We have to be a place where patients can come when they need us. The next one, sorry, this is small on the screen, is compassionate. Is that right? Let's see, I'm really lost, so so, and this is families when they walk into an office, and I've been in this situation before where I've walked in maybe during a slow time, and there's a little bit of chatter and stuff going on with the staff, and it may not always be in the best light, right? Families should be able to walk in and receive care that is compassionate. We should seek to understand. We shouldn't be, again, speaking to the choir, we really need to watch what is being said as families are in our clinics. We need to watch the language that we use with our families. Families that are non-compliant is the worst word I have ever heard in my life. We need to understand what their challenges are and what their concerns for their child is. So, continuous care. This is one of my favorites. So I love care along the continuum, right? So, ideally, a patient would start with a pediatrician, and that pediatrician would follow them into adulthood. And then we would so smoothly transition them into adult care, which you can chuckle if you want, because I know that doesn't exist a lot. But we also know that there's turnover in our offices. And so sometimes we're the consistent ones, right, as care coordinators or as the nursing staffs. Sometimes we're the consistent person in that office that is operating that for that the care along the continuum. They know they can call and they can be like, hey, you know what, I have a problem in the school. And I know you know the history of my child. And we can give that history to the provider and we can bridge that gap so that they are receiving that care along the continuum. The other part of this is that we should have, we should be helping make sure that we have all the medical records for this child, right? So that it's not like there's a carve out of cardiology, right? We don't know anything about the cardiology, what's going on with cardiology, but we know all the rest of it. right? So we kind of want to be that bridge to create that continuous care. And then I'm not gonna talk about a lot about the coordination because we all know this piece. Being, so the comprehensive, that goes very much into helping like the specialist, right? Making sure that we have a specialist knows that we are the center for that family when they need us to be. We might help facilitate conversations, across the different, specialties. And between primary care. Sometimes it's organizing, like a care management meeting. And families, I don't think they always see this part, and that's okay, right? And there's a lot of this they don't see, but they have a face and they know where to go when they need it. And then being culturally competent. So in the area where, in Park City, that I was a care coordinator in, there is a large population that does not speak English. I speak English. I don't understand these families, cultural. I understand some of their cultural background because I've had people filming in, but I don't have the lived experience. I can do my best to understand what their challenges are. It is better when I have someone in my clinic who can speak the language, who understands those challenges at a different level than I do, and understands that, you know, right now, we know that this child needs ABA. That the family doesn't have the bandwidth to get ABA in place because they're concerned about their family members that are living in their home. And how are they going to, you know, are they safe to go out and go to work, right? So right now, there's some big things with ICE going on and you have families that are scared. Some of these populations will tend to pull back and they'll only go to the most trusted sources. And so we need to be very sensitive to that. And there are other experiences. We have people who are refugees. I do not understand that experience fully. What I can do is I can listen and I can understand it to the best of my ability. And also understand that if they don't have the bandwidth to follow through on something, then I need to ask them what their priorities are and I need to support them where they're at. So, sorry, I feel like that's a bit of a soapbox for me. But I feel very strongly about meeting families where they're at. And doing my best to understand where they're coming from culturally, because I have my experience. So this is the data from the child from the survey I mentioned before that I asked her on. Utah does quite well. This is actually, I put this slide in there. And a week later, they changed the data, they put the new data up. And so I was a little disappointed when I looked at this, we were like, number one, like we had the top amount of families who feel like they have them from home, right? And then because of 55%, something like that. With the new data, we are still in the top 5, and we do a fantastic job of letting our families feeling like they have a medical home. But 45%, I don't know, what insight you have on this, like on what this split is, because it's like half of our families feel like they have medical home and half don't. So do we know how many are rural or how many are?
And stratified to a certain degree, or now the data, sorry. You can stratify the data, go into National Survey of Children's Health or Matthew Phillips, Utah, compare it nationally, or you can pull up Utah data and pull it down by like educational attainment and household. Does the family have Medicaid and certain things like that? This is a random survey, that's what's not. throughout the year. So this survey goes out to random families. There is a screener on the front end that determines if children special health care needs or not. If that's determined, they fall into the special health care needs pool. The rest of families just fall generally pediatric. So.
Thank you for giving us a little more insight on that. I love that we're in this. I'm so glad that we're one of the top states, so. And I think that's a testament to what you guys do. I'm sure everyone has seen, Durga's, toolbox. So this is, Kristen Lynn's, care map for her child. He is in the center. And I just want you to remember that, like medically, we're just this little piece over here, but there's a lot of doors. And part of our job is to help open those doors, right? We can help provide a key. We can help turn the handle. And when families need a little more support getting access, we can help with them. This is, again, another one of my favorite things. This is forever old, and I absolutely love it. So this is when they do studies about medical home, right? So this is kind of what they find. They find improved family satisfaction. I think that is probably the #1 outcome that we should be striving for. Decreased parental worry, decreased emergency room visits, less out-of-pocket spending and stuff like that. But the impact is really how we make our families feel and the confidence that we give them in the care we provide. And that's very much a testament to what you guys do. I wanted to show this again because I think one thing what is missing in the Lisa medical home and what the literature was, and that is integrated behavioral health care. As time has, passed and as the internet has become, what it is, and all the apps and the children have phones, we have so many more behavioral health problems with our kids. And they tend to turn to their pediatric offices first. They call the people that they trust to navigate these things. And so a lot of pediatric offices, as you guys know, now have integrated behavioral health in some form. Whether it is a therapist in the office, whether it is a behavioral health prescriber, psychiatry, an APR, a psychiatric APRN. And we've had to make these adjustments to fit the needs of our families. Let's see, so some of the things that are included are early screening for behavioral health concerns, early access, and early interventions, increased follow through for behavioral health referrals. I think when we give an outside referral, 25% follow through with those referrals, roughly 75% falls through the cracks. When we refer internally, I have asked about my behavioral health director, but it goes up substantially. The follow through does. We have decreased stigma. Sometimes just accessing behavioral health care in the office is enough to be like, oh, I'm just going to the doctor, right? We're already there. Our kids, that's already part of their vocabulary. It's not intimidating. And then increased collaboration between the primary care provider and behavioral health provider. It is so nice to be in a practice where a child is seen, the behavioral health provider comes out of their appointment, goes over to the PCP, and that conversation can happen right then. Or it's a short phone call, right? Because both, or a message in the system, because both providers know the patient and they can say, oh, you know what, they're still struggling. I know you put them on this medication, you might want to have an appointment with them and see if maybe it needs increase. Or, geez, they're doing great. They want to come off their medication and they ask us and those are just such great conversations to have. And we can be so much supportive of our families in that way. So this is how I think of medical home. I love that we empower families and we help give them skills, and we give them skills for a lifetime. And sometimes we're giving the kids skills for a lifetime. Anyway, I really like that. Here's my resources. They'll be included in the slide deck. That's kind of where I got everything. And then here's my contact information if you have questions. But more likely I have questions for you guys because you guys live this every day. Thank you.
Hello. Thanks, Dusty. So this is going a little bit hard for me to talk with the microphone. I am used to talk with my hands, so I might go in and out with the sound. So my name is Gabi Baraghoshi, and I am a quality improvement specialist and work at UPIC, which stands for the Utah Pediatric Partnership to Improve Healthcare Quality. And Athena, it took me about 2 years to get this out of my mouth, so you still have time to learn that. And I have worked with probably several of you on various GI projects. Abby, I'm looking at you last year, and Utah Valley Pediatrics back there. So it's great to see you guys. Today I'm here to talk about the collaborative care model, and from now on I will refer to it as COCM because it's probably much quicker for me to talk, to say. Okay. I have nothing to disclose. So, pediatric care model, COCM. So, Dusty gave a great overview about the medical home, and she also touched already into the integrated behavioral health, COCM. And in pediatrics, it has shown that the medical home plus COCM emphasizes a team-based, patient-centered approach to high-quality healthcare, specifically for children with mental health conditions. So sounds very promising. So why CSA? And also Dusty touched on that one. So the prevalence of behavioral health conditions in our pediatric population has increased over the past few years and will likely more increase. And I believe there's two factors in place. First of all, I'm still thinking it's the COVID pandemic. We're still feeling the effect of that one. And the pandemic really has done a number on our mental health well-being. And the second one is our screening process in pediatric practices really has improved over the last decade. So we're screening more often for behavioral health conditions. So we are identifying the conditions and the patient populations who would benefit of behavioral health therapy. Then in the US, I think probably everybody knows this statistic, in the US, suicide is the second leading cause for children between the age 10 and 14. And then we also know that if you treat a child early in their lifespan, once you recognize they have a behavioral health, mental health condition early in their lifetime, it comes to at least a better outcome and a better quality of life for the child. And then behavioral health services for the pediatric population is even more scarce than that for the adult population. And we all know that. There's no big surprises right there. Okay, so here's a map of the United States. It shows you the shortage of behavioral health professionals. The dark blue areas are the shortage areas. So if you look at Utah, so you can see in our urban area, we're actually doing quite well, but it's our rural area, rural communities who are struggling and really have a shortage there. So again, Dusty touched on that one. Integrated behavioral health is one of the solutions. And about 10, 15, almost 20 years ago, the behavioral health integration became a term that became more familiar to our practices. And the Affordable Care Act really supported that program or that solution and allocated more funding towards the practices, towards that model. So there's a 66% probability that a child who has some type of form of behavioral health integration therapy has a better outcome than a child who would not have that opportunity. And there are three very important components towards a behavioral health care for a child. The first one is it has to be population-based. So you got to identify your population. The second one, it has to be measurement-based. And then the third one is evidence-based mental health intervention. So the University of Washington, the AIM Center, took all of those three components and put them into a program, and that is the collaborative care model. So up to today, it has really shown the most promising solutions for an integrated behavioral health program. There are more than 90 randomized clinical controlled trials that show that children who have depression, like the adolescent depression, really improve much quicker with a COCM program, and also that goes for other behavioral health conditions. So where it has shown the most effectiveness is on adolescent depression, so 12 and up, and an ADHD, so children 6 and above. And then has shown some of the effectiveness is in childhood depression, so it's 12 and lower. Anxiety, suicide risk, autism, substance abuse, and general mental well-being. So it's not as effective as under adolescent depression, but it has shown some effectiveness. So there are standardized trait screening tools out there, and in the COCM program, you have to use standardized screening tools. So no off-the-wall questionnaire, so it really has to be standardized. And so I listed several of those up here for certain conditions, and as care coordinators, I know that you have seen them all and probably use them on a daily basis on your own patients. There would be the PHQ-8, the PHQ-9, if you don't have the PHQ-8, the GAD-7, the SCARE, the Columbia Suicide Severity Rating Scale, the CRAFT for substance abuse. So there's so many out there. Okay, now I've talked about the COCM. So what does it actually look like? So here, the graph, you see the team members, because it's a team-based approach, so the team members. And as I mentioned before, it's also patient-centered. So here you have the patient, the family in the center, and then you have the other team members. Oh, I'm wearing my name on my... And then you have the other team members around it. You have the primary care providers, you have the psychiatric consultant, the behavioral health care manager, and then also a registry. And I will talk a little bit about each role, each of those persons' role now. Let's start out with the patients and family. So the patient family has to consent to be enrolled in COCM. And they also have to agree to actively participate in the program. Then we have the primary care provider. The primary care provider basically just endorses the program, talks to the family, hey, we have this program in our clinic, and I think Johnny really would benefit from being enrolled. So the primary care provider can either consent or refer for somebody else to consent the family to be enrolled in the COCM program. Then we have the psychiatric consultant. So the psychiatric consultant really doesn't see the patients, but via case review or case conferences, how you call them, they can provide their input on diagnostics, on treatment plans, on medication management. And that happens on a weekly or monthly basis. And then we have the behavioral health care manager. And I will talk about the behavioral health care manager's role a little bit more in detail on my next slide. So right now I would like to talk about the registry. So for an effective implementation of a CUCN program within primary care, there's a lot of task sharing going on between the team members. And the registry really can help with that one, where you keep track of the children who are enrolled, who is reaching out, how often do you reach out, what are the follow-up scores on the PHPA, do we see an improvement? Is it getting worse? Does the kid need to be referred out to somebody else? So these are very important points you gotta keep track in your registry. Okay, the behavioral health care managers. So is responsible for many of the core tasks within a CSCM program. So facilitates communication, acts as the main contact for the family, does care coordination, and also can provide evidence-based brief interventions, like the FAST program. I don't know if you have heard about the FAST program. It stands for the First Approach Skills Training. And I will talk about the FAST program probably within the next couple of slides. So in some pediatric practices, the tasks for a behavioral health care manager is split into two persons, so it can be divided into by two persons. So we have the clinical provider who has the license to actually deliver some brief behavioral health interventions. That could be now a social worker, could be an RN, could be a counselor or a therapist. And then we have the care coordinator on the side. And the care coordinator's job, and I'm pretty sure you know all of them because it's what you're doing on a daily basis, is really kind of providing maybe more specific information about the CUCM program to the family. Or they do the follow-up phone calls with the family and do the PHQA on a weekly, bi-weekly, monthly basis with the family. They can be also the main contact person for the family. They are reporting or documenting and maintaining the registry. They help in the referral process. So everything that he mentioned before, that will be the task of the care coordinators in the CUCM program. Okay, so I mentioned the evidence-based brief behavioral interventions. So there's this FAST program, and the First Approach Skills Training, and the University of Washington and Seattle Children's Hospital, they provide module for learning for care coordinators or behavioral health care managers or even providers to learn how to do brief behavioral interventions for the family. It's a mouthful for me, sorry about that. So here's the website if you can go on, and Athena, you're going to send this out probably into the post webinar, post meetings email. You can go there, you can explore it. It is free, so there's no cost attached to it. So there is the modules of, let me go to the next slide. There's some program training videos. Plus, there is a link where you can download some workbooks that you actually can provide to the families you're working with. And there's different FAST training videos for different conditions. So there's a FAST A would be for anxiety, FAST B for behavior, D for impression, and so on. So FAST T for trauma. There's for parenting teens. I definitely could have used that one when my kids were teens. And there's early childhood. Okay, big question. Can you build for CUCM? And the quick answer is yes. We're still trying to, and thus we were talking about this before our presentation, we're still trying to figure out, is it actually feasible or is it really worth the not the headache, but the work to implement a new program, and then you don't get the financial reimbursement for that one. And we both came to the conclusions, we gotta learn more about this a little bit. It's still early in the game for us. But yes, so if your practice provides an active treatment and care management for an identified patient population, that could be your depressed children or the newly diagnosed depressions, and you use a patient tracking tool, which is again the standardized screening tools like a PHQA, and you use a registry where you keep track of your caseloads, where you keep track how many times you meet with the psychiatric consultant, how many minutes you spend on that one. Again, the registry very helpful. Then yes, you can build for it. And here would be the billing code, just in case somebody's interested again. The first month, 70 minutes, so you gotta keep track of how many times you actually spent with the family. That could be now a phone call, it could be an in-person visit. The case conferences you have with a psychiatrist goes in there, the conversation with the pediatricians goes in there. So everything should go in there for the child. And at the end of the month, before you close out the chart, you write in how many times how many minutes you spent in there, and then submit the billing code. And that pretty much was my presentation on COCM. Any questions for Dusty and me? Yes.
Higher for skills CM versus chronic dementia themselves?
Don't know. As I mentioned before, I'm still kind of new to the game. Dusty, do you know?
So we've been doing COCM in our Park City office for a few years, and I think Utah Valley, you guys do. So I think the COCM codes they do pay higher than the chronic care management codes, if I'm remembering correctly. I will check when I get back to the office. I'm sure that these guys might know.
Yeah, and I would agree with Dusty. I believe it is higher than what you mentioned. And the model utilizing pediatric care, we have actually contracted with an outside psychiatrist consultant on that one, right? Is it correct, of the Vargas team? Yeah, so it's probably totally steep learning curve to learn about their process. But it sounds really good.
So that we learned from Gabi and Dusty today, and just kind of a refresher about like what is medical home, what are some of the services we can provide as care coordinators, how has care coordination kind of evolved over the last 10-15 years, especially here in Utah, and with integration of behavioral health, I think it's really important to touch on as well, since that's kind of a new piece for a lot of practices. So we're so glad you could join us today. We will meet again on May 21st, back virtually. And for that meeting, we have planned an update from Title V on the needs assessment that was done recently, and some of the results throughout the state of Utah. So as always, we encourage you to stay connected. We have a Facebook and then the listserv, and I'm just going to touch on this because I know sometimes the listserv is confusing. So if you email this email address directly, it will send out announcements to the whole listserv. Or you can email them to me and I'll push them to the listserv. That's an option as well. So that's kind of how the listserv works. But if you mail something directly to that email address, it will automatically send out to the entire listserv. So if you have an announcement coming up, or you want to share something with the whole group, or you have a question, a case, that's the fastest way usually to get responses on cases, especially is if you send it to the whole listserv, and then if they reply, the the message will go back to the whole lister as well, so. Great, does anybody else have any final questions, announcements, comments you wanna add? Yes.
Just how many offices are building or having success building for care coordination? So not the co-care management thing, but like actual just care coordinator, care coordination services types of facts.
So, I'll say that we tried to build one up before and the reimbursement wasn't there. We haven't tried for nothing, it's been pre-COVID, it's been much tried. Have you guys tried? If you want, maybe we could get together and, maybe between our practices, try and build a couple, it's through a couple different insurances and see how that goes. And then get back to the group, and if it's viable, you know, it looks like it might be viable.
It's good.
So I work with the University Health Plans, and I know I see, when I do my claims review, I see care management going through monthly for some people. Yeah, or
Do that, and I'm also at University of Utah Health, and we have several clinics that are building for their entrance.
yeah, the claims review.
I think when I looked up information, it seems like only one place can be billing for care coordination at a time. So if they're seeing a specialty that's billing for it, then their primary care can't bill for it as well.
Yeah,
My understanding.
right.
You know, microphone is all not. I know that years ago, that was the way it was almost like Apple, it's like.
What?
Then you get the billing in first. Or it was the last person bill in the month up in B, so if you had multiple, care coordination.
Whoa.
You know, everything had changed over the years, and so. Interesting enough, something it's still pretty similar. Do you want the rates, for lack of any changes?
What can I help you with? Okay.
Yeah, I know the rates were swallowed back in the day.
Are you scared? Are you mad?
Sound is gonna be somewhere else, that's like the full.
Yeah, sorry, it was, I think Natalie, Alan, do you have a question? She was just here, so that's what it's like, oh, she's online too. She had a meeting. Let me just check the chat online too, because she's online either. Anybody else? Okay. Well, we'll wrap up for today. Have some extra breakfast, so if you need a second breakfast, if you're a hobbit, please grab me or just meet attending to breakfast every day. So thank you everyone so much for coming, and we'll see you all again next month.
Tried to shut it off.
You were right with my notes.
Oh, did it shoot? I saw